Hey there.
Tournament. So doing this live from the car and working at the beach today. Not too bad, to be honest. Not a bad thing at all. Hopefully we're doing good with our cell phone service. I've been working all day here, so hopefully it's going to work out. And Catherine, I see you here and should be able to have you join live. I know, here we go. We should be in. Let's see if this is working here. And thanks for being patient with us as we get Jaimy and Katherine here. I know they're actually together in Colorado, and let's get you in. And going to join us live to talk about the Otolith assessment, and
Yay!
we made it. Yay! You're both here. Awesome. I'm so happy. I'm joining you from the beach today. I hope the signal doesn't go out, but I've been working all day on this cellular service, so hopefully that works. I first, because I talk about Jaimy and Katherine like you're one person. Jaimy and Katherine, Catherine and Jaimy. It comes off my lips, and I call you the dizziness duo, neuro PTs. But for people that haven't met you, do you mind introducing yourselves? Because people have to know who you are.
There we go. Sure. I'm Jaimy Wahab. I'm a neuro PT out here in Colorado, specifically Boulder, Colorado. I treat a wide variety of neuro patients, but I think my heart's there with those vestibular patients and treating those complex patients. I also teach at Regis University, which I'm a graduate of as well, and I think that's about it.
And I'm Catherine Dynas, also neurovestibular physical therapist in the Denver metro area. My husband Eric and I have an orthopedic. We have a mobile physical therapy practice together. He's the ortho to my neuro, and we're so fortunate to work with some amazing other therapists as well. Jaimy and I met back in 2004. That's been 19 years. Yes. So we worked together for a couple years in an outpatient clinic that was heavy vestibular neuro, and then have each branched out on our own since. So we've maintained our friendship over the years, and for the longest time we'd say, we really just need to teach that. Like, I don't think people think of it this way. And then when the pandemic happened and Julie started Brain Bites, we connected that way and just sort of came up with positive spin on dizziness, and it's evolved from there.
Exactly. Well, I tell people all the time, like, you both changed my life, and in many ways, but I think especially in the approach to dizziness, complex dizziness specifically, like, I think a lot of us kind of, we get our vestibular rehab and we do well with certain types of patients, and that's how I was feeling and how many of us felt. And then there would be those things we got stuck on. And I think it was really through our Brain Bites sessions where people would bring cases and you both would share an approach that I was like, wow, this makes a lot of sense, and I had not thought about it that way. And I was not the only one. Like, we were all feeling that. And so yes, the world needed positive spin, and I'm so glad that you did. And the world needed the Otolith, to come back to the forefront. So I wonder if you can share a little bit. I know we have this brand new free cheat sheet that we've been sharing with everybody. By the way, already 500 people have downloaded it. That's how much the world needs the Otolith. It's awesome. I mean, I think it's not surprising at all, because therapists get in complex dizziness. So what you have created is so helpful to the world. I wonder if you could share why Otolith, and then we can share a little bit about what's in the cheat sheet and what's behind the cheat sheet.
I think Jaimy and I would discuss a lot. Like, I don't, it's been years of saying like the otolith's just not appreciated. Everyone's so focused on the canal and BPPV and VOR, which are certainly all important and they all have their place. But the otoliths are huge in sensing our gravity and knowing upright, that if those aren't functioning properly, it almost doesn't matter about the others. If you can't tell which end is up, everything else is askew. So we just had those conversations many, many, many times over. And I think we just kept saying we need like Otolith Appreciation Day, which became Otolith Appreciation Webinar and half of Positive Spin on Dizziness. But that was really like just recognizing that it's a huge component to assessing a person's dizziness and their perception of where they are in space that gets overlooked, that kind of drove us to.
And I think the literature just wasn't catching up to what we were seeing and what we were trying as clinicians. And years of, what do you think it means when a person says this, Katherine? Or, you know, when they feel floaty, when they feel, you know, off, or when they're being pulled to one side. So really analyzing what's the function of all these, of the otolith versus the semicircular canals, and diving into, well, if you don't know what straight is, how can you spin on it? And so it really did change our practice, and I would notice it. I'd get referrals from other PTs to sort of cross refer, and it was all these simple little tweaks into looking into the otolith, and the patient could kind of progress through their just sort of a typical vestibular program after it. So it was just, I've always said it was this great, we found you, which was exciting, and we found brain bites, which was wonderful. I've always said it's the silver lining to the pandemic. And it was, it gave me insight into how other people think about especially experienced clinicians, how we were thinking about vestibular rehab and pushing it a little further. And you know what it did? It pushed Katherine and I to really dissect the literature and explain what we were seeing, which is what Positive 1 and Positive 2 ended up doing, which just, it was exciting to find all these, all the different literature that really put together and explained people with migraine or vestibular migraine, people with MDDS or Maladie-Debarkman syndrome, and certainly even with Meniere's or vestibular neuritis. So yes, the complex dizziness that just needed to go a little bit further. It's been a really fun journey for really the two of us, but including you, Julie.
I'm riding the wave. I'm riding the journey with you. Yes. Well, and I think you're so right that I think that idea of there's dysfunction and hypersensitivity, right? And this was one of the biggest pieces that I took home from Positive Spin 1 and learning about the otoliths as well. And this was coming up a lot for a lot of clinicians in all the systems, right? Like we were talking about it in the sensory systems and motor control and all of those things. And it's kind of like a similar thing, but in the vestibular system, and particularly with the otolith involvement. And I think, you know, this is not taught in schools, otolith assessment. And because frankly, the vestibular system is hard enough, right? Like I know you all teach it. I teach it at USC. It's hard enough to get a hold of the basics of the semicircular canals and hypofunction and BPPV. We don't really need another layer in schools, but it's not taught in schools. But there's so many patients that I might have maybe missed some of these pieces because I didn't assess it specifically. So I know in the cheat sheet that you created, it's for otolith assessment, and I wonder if you could talk about what are the components of that objective assessment, and also the why. Like, why are those pieces particular to the otolith? What's important about that? I know people have asked a lot of questions to you. What about subjective visual vertical and all of those things? So I know we have lots to share today, but walk us through that otolith.
I think the first place we start is really just observing the patient. Do they sit or stand in midline and upright? Do they have that sense of orientation? Because if they don't, that's really where we need to start, is can they tell? And Jaimy had a great patient case in positive spin 2, where the patient is just leaning so far over and really does not recognize that that's not upright. And Jaimy puts her back in midline, and she can see in the mirror, like, okay, I know that I look vertical, but this does not feel, this feels so weird. And so, you know, she's maladapted to being tilted quite a bit off axis. So that's really where we start, is just that observation. And can we get them to midline? What are our tools for that? And often that's involving like playing with weights and help that graviception, increase the somatosensory input to help reinforce that true upright is here and not 20 degrees off to your left.
Right. Which can be severe. It could be very mild and subtle. But again, then looking at, okay, well, sitting, they look okay, but how do they look in standing? And do they, even diving into their perception, which perception was in PS2, right? Like diving into the perception of motion and the perception of vertical and upright, which I think is a game changer, because the vestibular system got this big hype, but we had to think about the visual system, the vestibular system, and the proprioceptive system, and how they're integrated and weighted centrally. So, so then looking at, you know, what are they leaning to the left or right in standing, and what happens when we give them weights and give them graviception. I think for years we thought it was just proprioception. But the more, again, we started looking at it, it was no, I think this is giving them the perception of gravity as well and enhancing graviception. And it was a beautiful way. And I think that's where people latched on, because the success is really fast when you try that with your patient. Their buy-in, their understanding, it makes sense to them. And you're giving them something that is not necessarily provocative of symptoms, but lessening their symptoms and making them feel better, so that you can actually start them from a better baseline than where you were before.
And that's really sort of the MO of vestibular rehab, right? It's like, we have to make you worse to get you better, but we can also help you just feel better. And then you can, you know, you have that sense of agency. Then, okay, now I feel more comfortable doing the things I know stir me up, because I have this tool that helps to settle the symptoms back down. And then Jaimy, you were mentioning just kind of that it's really like a misnomer of vestibular rehab. It's really dizziness rehab with the sensory function, right? And that's where subjective visual vertical comes in too, because it really is assessing otolith function, but giving us an idea of how visually dependent is a person. And then it helps us to dig into the why. Is it because the otoliths are not functioning properly? And then there can also be somatosensory altered input as well, if there's some cervicogenic component to it, in addition to otolith, which we see a fair amount of. But the good old bucket test, and Re+active has a great how-to on your reactiveeducation.com, right? And I think also linked with YouTube to find how to do the bucket test for subjective visual vertical, but a quick and easy test to just get a sense of where a person feels upright is. The other parts that we look at are very simple, like sit to stand, right? That's because the otolith is a gravity, like in linear acceleration. Does a person get more symptomatic just moving? And I don't think we typically think of that as part of our vestibular testing, but that absolutely stimulating the saccules with that vertical motion. And then does it change when they close their eyes and they can't rely on the visual cue anymore? We're biasing that saccule even more. How do they look with the eyes closed, and then throwing the weights in as well? So we have a lot of ways to take simple tests and just tweak it a little to bias for the otolith input.
Right.
Yeah, I love that.
We're all about simple, right? Simple, and you don't need fancy equipment. And same with like doing a Romberg. And then if you do Romberg and have a head tilt, that sustained position out of line with gravity is again stimulating the otoliths. Does that change how a person's balancing, or do they feel worse? Do their floaty symptoms, they're rocking or being pulled to one side, is that enhanced with that head tilt? Or for some people, if we're now lining up what they perceive upright to be, they might feel even better. So that can be very telling as well.
Yeah, it's just taking what we already do and putting a tilt on it. Or a weight.
Which is another thing we look at. How do we do
on a slam board?
A slam board, either dynamically with the shifting, are they righting their head to gravity, or a static tilt? Can they, again, like in the mini best test, can they find true upright, or do they align with the surface? And that's very much a function of otolith, is finding gravity and keeping us upright. So also simple tests, things that most of us already have access to, that we just use in a little, with a different lens to help us to tease out why a person's feeling the way that they are.
Yeah, I love, that's what I love actually about the cheat sheet. It's like, oh, I've seen all of these tests before, the Romberg or tandem, but just adding one more layer. And that's actually so great for a therapist. It's like, oh yeah, I already kind of have my typical exam. Let me add one more layer. Does this make it worse? Does this make it better? And then the beauty is that goes right into treatment, right? Like, so beautiful.
Yeah.
And this is your homework.
Great.
You
go home.
Yeah, exactly. And I know in the courses, PS1 and PS2, you go so much more into how you interpret that, how you bring it into treatment. But one of my favorite pieces was this like off switch, which you kind of alluded to, Katherine, is like, wow, this might uncover in the assessment, you might uncover that off switch, and then, be able to take somebody into a little more provocative piece, but then have that that dial to turn back the symptoms. And I love that terminology. I had never used that or heard that before meeting both of you. And now I literally told somebody the other day who did a consult for our program and was working with a vestibular therapist and had not yet found a way to dial back her symptoms. And I was like, oh, let's talk about the off switch. And I wrote her a long email to bring to her therapist to explore off switch. You know what I should have done is sent your cheat sheet. So maybe I will follow up because it's so helpful. It is so helpful. I'm curious, maybe one last piece about the cheat sheet. How do you envision that this could be helpful for therapists? Like, how would they use it?
I think it sort of streamlines, like, say you've gone through your assessment already and you feel like, I'm just not making enough headway with this person. They're not really feeling a whole lot better. How can I take elements that maybe we've already looked at and tweak them slightly to again, bias those otolith? And so we've been doing Romberg. What if we add in the head tilt? Or we've been trying to do a tandem stance, but now I'm going to look at it. Are they head riding with that? And what if we focus instead on, how long you can balance in that position? We say, Jaimy and I all the time tell people, don't worry about your body, and external focus using a laser, just working on the head riding itself, where you initially have more of a visual cue and then can back away from that. But you're taking pieces of an assessment you've likely already done and just emphasizing in a different way. So we're really focused on the benefit of the Otoliths and getting those to work better. Anything else?
Yeah, I think the same. I keep thinking the course dives into it so much more and then takes you through the whys of what they all mean as well, so that you can explain to your patient as well, understanding that our otoliths are graviceptors and there are sense of verticality. I loved it when we got into eigenvectors. That might have one of my favorite ones that I'm still using today. It just starts to make sense. And I think then what happens is you start listening more and more to your patient, and it gets easier to pull out like, I got to do these tests on you because you have looked to your live the other day what the subjective is as well. And they all start to come together and flow and get, I think, quicker outcomes. I think I think again, teaching them that control of being able to settle their symptoms or use the off switch is huge, so that I really think that adaptation then goes into movement and how movement stops. That goes into perception of motion as well, which is in PS2. Anyway, I'm whole thing, and I just see the whole cycle of
but
it is
with the cheat sheet at the beginning, like you had mentioned in your Instagram live, Julie, with the subjective portion, just knowing what to listen for. And that if a person says, I feel floaty, or I just don't feel like I feel the ground well, that it just helps to guide where you're going to assess next. I think that those are really key things, that instead of thinking like, well, I'm not really sure why they're dizzy, maybe if we do enough VOR, that part will go away, the floaty, and just no, it doesn't.
No. It doesn't. From experience, it doesn't. Now, somebody had commented on here, wait, what are we talking about? And so I know we kind of got deep in the trenches here, but we have been talking about the ever forgotten otoliths, and specifically that we just released brand new updated Otolith Evaluation Cheat Sheet. Oh, look at, they've got the printout. So this is downloadable on our website. If you go to reactiveeducation.com, there's a button right there. If you go to reactiveeducation.com/Otolith freebie, you can download it. I'll send it in our newsletter today. We will, and again, 500 people. We just released it on Tuesday. It is Friday. 500 people have already downloaded it because honestly, so much of us get stuck with dizziness. And so it's not surprising to me that this is so helpful. And when people download it, by the way, Jaimy and Katherine have been great. They've put together a couple videos of how it's used. Katherine's the model. And so we actually set up, when you download it, we'll do a series of emails that come after each day, a little tidbit of how to use it in evaluation, so that you can really use this. And like Jaimy said, like Katherine said, people get better so much faster. Like literally day one, things that I was missing for months. So, and honestly, that's why the Positive Spin series of courses that you do have been so popular too, because people are seeing changes very quickly in their patients. And I'm not claiming miracle drugs. I'm not like claiming any quick fixes, but sometimes when you've overlooked a part of the system and then you don't overlook it, things get better. So that's what we're talking about. We're talking about this free resource that Jaimy and Katherine created that we have put out because we have declared Otolith month here. We're going to be talking about it all month because we want to help people with chronic dizziness or complex dizziness get better. And we're on a mission. We're all on a mission. We're on a collective mission. So go download it. It's at reactiveeducation.com. Big button at the top for the Otolith Evaluation Cheat Sheet. And I know, Jaimy and Katherine, we're going to keep bringing you on to keep sharing little tidbits that can help people with complex dizziness, and you can follow. They'll share a lot together. There's tea time with Jaimy and Katherine. You can follow Katherine at Step Up PT, and a lot of times I know I'll see you both hop on there with some of your videos. And Jaimy, I know you're tagged in here as well. It's
WW.
WW. I was like, there's two letters at the end. Yes, JVWW. So you'll have to follow them as well, because I know they're on a dizziness kick also. So we'll be sharing a lot this month. Any last pieces you want to share before we sign off?
We're so excited that 500 people have already downloaded it, and we'd love to hear feedback and questions from folks about how they're using it, what's going well, what they're not quite sure about, because like you said, we'll come back on again and we can address some of those concerns people might have, or you know, make little suggestions. But if you are enjoying it, there's a whole positive spin on dizziness series that really is the deep dive. Like, this is the just tiny little snippet of how to look at the otolith and how to use it. And so for people who really want more, those resources are available too.
Yeah, that's great. That is great. Well, I think we'll be getting some good questions. So I'm excited to bring y'all back next week too and answer some of those. And again, if folks are on and want to send a direct message, we're happy to do some lives, answer questions about this, because it's not something that's necessarily covered in school for therapists. And I know we get questions from patients too. And so I always tell people, share this cheat sheet with your therapist. It's so helpful. So thank you, both of you, for joining me today. I'm glad this worked, even while I'm at the beach. I can't tell you how many surfers walked by as we were doing this. Like, so many, maybe about 20. So anyway, so great to see you both. Thank you so much, and thank you for this amazing resource. I think it's having a huge impact on the world of therapists.
Julie, we appreciate getting to join you. Enjoy your rest of your beach day.
I will. All right, bye.